Great. So just taking just a moment to just acknowledging the traditional owners of the land in which we all are from all around Australia. Just acknowledging their incredible contribution to their country, our country, past, present, and emerging. And just want to acknowledge all the altars from around the world who have been serving these medicines for thousands of years. And just really hoping that we can give these medicines, justice in the Australian context, in the medical context, as we, try and bring these ancient medicines to the mental health system in Australia. So, welcome everyone. My name's Dr. Alana Roy. I'm the National Practice Manager at Mind Medicine Australia, and I'm also the co-lead on the Certificate of Psychedelic Therapies. And I'm super excited to have Dr. Benjamin Malcolm here today, also known as the Spirit Pharmacist. And given our technology issues, I'm not going to go through the Mind Medicine slides today. I'm sure many of you have heard some of our presentations before, but just briefly, obviously, Mind Medicine is a not-for-profit charity founded by Tanja Jong and Peter Hunt. We're a small team of very hardworking people on a massive mission to bring psychedelics to the mainstream clinical setting, to make it as affordable and accessible as possible. So Ben, have you got slides you want me to share the screen with you?
If I don't know, if you've given me host capabilities, I can just share them directly.
Yeah. Okay.
Well, it's truly a pleasure to speak with you all, and yeah, thanks for your patience while we worked out the difficulty and switched over to the meeting. Do we have a hard stop here at an hour and a half, or at 10:30 your time, or is it okay if it goes a little over? Does it?
Yeah, I've got to head off at 10:30.
Okay.
So that's why I didn't do the Mind Medicine presentation, which normally takes 20 minutes. So you've got the full stage.
Sounds good. Okay, well, let's get into it then, huh? So, obviously psychedelics they're federally illegal in the US. I believe it's pretty much the same in Australia at this point. So we're essentially going a little bit off script and talking about either illicit things or experimental things from a therapeutic context. So please know that, although I'm going to be talking a lot about the therapeutic potential of these substances, I'm not recommending that you break the law. I don't have any conflicts of interest to disclose, meaning that I'm not paid by any company that is developing any type of psychedelic or really any mental health treatment. Really, I like to keep things that way. And you're going to see a lot of images that I created throughout this slide, and the company that I created through, BioRender, really likes an acknowledgement. So there it is. Now I'm going to tell you a little bit more about myself at the beginning. I'll go quickly through that so we can get to the presentation. But essentially, going to start by talking about how different types of antidepressants work, mostly SSRI types, and then I'm mostly going to compare it to psilocybin, and particularly MDMA, because there seems to be a little more interaction potential there and a lot more data to talk about and discuss. But I will be mentioning a bunch of different types of antidepressants with, kind of the probably most popular types of psychedelics, are the ones that are being developed for therapeutic purposes. And then we'll kind of talk about this interface between antidepressants and psychedelics a little bit, as well as antidepressant tapering. And I really hope that we have some time for audience Q&A at the end.
Ben,
I thought I would.
Sorry, are you able to make your screen bigger? Because it's only on part screen at the moment.
I don't think I'm sharing.
You go the top right button potentially.
Is that better?
Yeah, perfect.
Sorry, I was sharing the wrong screen.
Yeah.
There we go. So I thought I'd do a little bit of icebreaker for you. You guys are down under. So I don't know if anyone wants to throw it in the chat box or yell it out if you know it, but where in the world is
See,
Sorry, Ben, can you just unmute yourself? Because I've muted all the participants. There we go.
Yeah, basically I was asking where in the world this is. Anyone has any ideas? Looks like Veronica has an idea. She's on mute though. Here.
California?
Good guess, but not quite. This is actually from, I was looking at the internet, and this is actually Hobart, Tasmania. And this picture is actually taken from Malana Road, which is the street that I grew up on. I lived in Tasmania from age 0 to 10 before migrating over to the United States. So don't be fooled. I lost the accent. I moved at a time where, the neurodevelopment was still kind of happening. But there is a Taz devil in the house, so I feel very connected to this audience just by virtue of that. I'm not going to take you through my entire educational journey blow by blow, but essentially at this point, I'm a board certified psychiatric pharmacist, which means I've done like advanced residency training beyond my like pharmacy degree in psychiatric pharmacy, and I've passed the board certification exam. And for the last 5 years, I was essentially teaching and working as an academic pharmacist. I got kind of burnt out about that, and was also just doing so much with spirit pharmacists that at this point I'm just kind of fully dedicated to my efforts there as a psychedelic educator and psychopharmacology consultant. I really appreciate the clinical data that is coming out of these experiments. It gives us a lot to talk about and gives us pretty much the most accurate look at safety and efficacy of psychedelic therapies that we've ever really seen before. But my personal belief is that psychedelics can be used safely in other types of supported settings, and they should be available for things like psychospiritual well-being, personal development, ceremonial sacraments, as well as treatment of mental illness. So although I am a clinician per se, my personal beliefs are that psychedelics can and should be integrated into society, into a broader type of context. And really what I'm about is kind of filling this gap between, well, we're coming out of a very long period of prohibition and essentially psychedelic hibernation. So I find that most people don't really know very much about them, or what they know about them is essentially very like unbalanced, because all they've ever heard is kind of harm related things, but they haven't really heard the therapeutic related things before. And then also just the how to stop antidepressants or how to stop psychotropics or manage them in general is a vastly under-researched type of area. And spoiler alert, we'll see in the presentation that most types of antidepressants probably don't mesh very well with many types of psychedelics. So I really see this sort of transitional gap between standard types of psychotropic medications like antidepressants and psychedelic therapies as an area that is going to become extremely important as the psychedelic renaissance, as it's sometimes called, continues to unfold. And essentially, this is what I'm focusing on, is the kind of interface between them, not only in the presentation today, but in a lot of what I do on a daily basis. So I do offer like private consulting types of appointments. They're like hour-long face-to-face. These are great for patients that may be considering different types of psychedelic therapies or wanting more information about how to wean or taper their current meds, want to know how they interface. Also have different types of educational courses available, one of them specifically about antidepressant tapering for psychedelic therapies. And I'm also developing a psychedelic pharmacology master series. It's a 3-part master series. Only the first part is done right now, but the other 2 are in the works. And especially the second part in the series, the slides are 80–90% done. It's just about filming and putting it up later this summer. Offer a membership program which essentially combines these 2 types of things. So all of my like webinar, course, education types of materials with kind of discounted consulting rates. So essentially, I'm really incentivizing membership by kind of putting what I consider the best of my offerings all together in one type of package. Membership could be for many different types of people. So it could just be for patients or clients that are tapering meds that want some more oversight and guidance in that process, or want to access educational materials as they go. Facilitators that have questions about psychedelic therapies or traditional psychiatric medications. And I also have like a discounted membership program that's purely for students. So it doesn't really include the individualized support, but all the educational resources they can access for quite a bit less than the standard membership rate. All right, enough selling myself. Let's get to what we came to talk about today. So I'm going to start with just comparing antidepressants and psychedelics a little bit. And both of these types of treatments or therapies appear to be effective for particularly mood and anxiety disorders. I will say the psychedelics seem to have an edge in that they're effective for substance use disorders, or at least certain types of substance use disorders as well, whereas we don't really think of antidepressants as being treatments for addiction or substance use disorders. Both of them work on serotonin, or primarily on serotonin. So that's a big kind of overlap, and probably a reason why there is some interaction potential between the classes of meds. There's a real overlap in the type of mental health conditions treated. So, whether it's depression, anxiety, post-traumatic stress disorder, obsessive compulsive disorder, other acronyms for psychiatric conditions, it seems that there is a lot of similarities between the types of indications that standard antidepressants are used for, as well as the indications psychedelics are being studied for. And there are, some ketamine, for example, that seems like fairly compatible with traditional psychiatric medications, but most of the serotonergic ones probably aren't that compatible with traditional antidepressants, either because they're kind of counterproductive and diminish effects, or they could, increase physical risks or actually be dangerous in combination. And we'll spend quite a bit of time unpacking that a bit more. And so really kind of thinking about it, it seems that if psychedelic therapies like MDMA or psilocybin-assisted therapy were to be approved, these two treatments would be kind of butting heads. They would be poised to be competitors in the marketplace rather than things that mesh well with each other. So again, this is why I believe that this topic is so important, particularly talking about antidepressants with serotonergic psychedelics. So typical antidepressants, and my example here is SSRIs. They're the most common types of ones, or are taken daily. They don't work immediately. They tend to work over weeks to months. They're taken for an extended period of time and tapered. It depends on what illness and what guideline you look at, but anywhere between 6 and 24 months is the types of durations of antidepressant treatment that are recommended out there, like per episode. They're prone to risks of acute and long-term side effects, as well as physical dependence and withdrawal, because you're taking it every day for extended periods of time. So you can get acute side effects when you start them, or long-term side effects. And then after that period of time that they've taken them, a lot of people find that the dependence and withdrawal syndromes from standard antidepressants make it difficult to stop them. Psychedelics like psilocybin or MDMA are taken intermittently or even infrequently. It seems like the models so far use 2 or 3 sessions of psilocybin-assisted therapy or MDMA-assisted therapy. It's a model of accompanied support, so this is not at-home drug taking. It's always done under the supervision of, at least in clinical trials, licensed professionals. And there's also, a greater therapeutic intervention in that they're, meeting with them beforehand, between sessions, as well as afterwards. They're taken for a number of sessions. I mentioned that. And the risks of psychedelics are kind of prone to risks of user vulnerability because of the non-ordinary states of consciousness they produce, the suggestibility of those types of states. They can also cause extreme type of psychological effects or experiences that in the wrong sets and settings could not heal trauma, but essentially traumatize the person further. There's behavioral risks associated, again, with unsafe sets and settings mostly. And, post-use effects are, not that common as far as like really like precipitating psychosis or bipolar disorders. That's really only people that have like predispositions for those things who are probably contraindicated to take psychedelics in the first place. But sometimes people get their world rocked really hard. The ego can be kind of completely shattered, and when Humpty Dumpty falls off the wall, it takes a while to put all those pieces back together, and the person can really feel sometimes depersonalized, derealized, and that can be really anxiety provoking and really cause a lot of things to be stirred up in the aftermath of some of these bigger experiences. It seems like psychedelics and antidepressants work differently, even though they work on serotonergic nervous systems primarily. They tend to activate different sets of coping mechanisms. So my analogy for traditional types of antidepressants like the SSRIs is weathering the storm or passive coping. And they tend to do this by decreasing emotional sensitivity. You could say in a sort of positive light or a positive connotation that it increased their resilience or enhanced their tolerance to stress. Also have some patients tell me that, for example, I felt like numb, I felt like a zombie, I felt like my emotions were blunted. So maybe those are essentially two sides of the same coin, and it sort of depends on the user whether they like that effect and feel that that's helpful for them, or that they feel that their emotional range was kind of narrowed and didn't really get them to the place that they were after. On the other hand, psychedelics tend to inspire transformation or change or active types of coping mechanisms. They tend to increase neurotrophic factors. They tend to enhance neuronal plasticity, and they tend to dial up a person's emotional sensitivity. So this is essentially kind of inspiring people maybe to just go out there and tackle things or make changes in their life. And this is a little bit reductionistic here as far as, okay, well, psychedelics definitely also work on serotonin 1A receptors, and there's a bunch of literature talking about how psychedelics do affect the limbic system. And similarly, when an SSRI blocks the serotonin reuptake pump, it blocks it at all serotonin synapses, yet mechanistically, it's usually the serotonin 1A receptor that gets talked about the most as far as the mechanism of action of standard antidepressants. So take it with a grain of salt, but it really appears that they do different things fundamentally as far as changing the way people's emotions and coping mechanisms are working. Okay, so let's talk a little bit more about like pharmacodynamics now, or sort of specifically the mechanisms of some of these medications and substances at serotonin synapses. So this is just a standard serotonin synapse. Maybe you've seen diagrams like this before. Usually in the presynaptic neuron, serotonin synthesized from tryptophan gets stored in vesicles. It would be released into the synapse with an action potential, an electrical signal coming down this neuron. And then once serotonin is in the synapse, it can bind to postsynaptic receptors. It can be degraded by monoamine oxidase, or it can go back into the presynaptic nerve terminal through the serotonin reuptake pump. And you have lots of different medications out there that target different players in this serotonin synapse. So we'll talk about MDMA, SSRIs, and things like psilocybin, but maybe you've heard of like monoamine oxidase inhibitors, either in the world of traditional pharmaceuticals, things like meclobamide being a reversible monoamine oxidase inhibitor, or some of the older ones, phenelzine or tranylcypromine being kind of irreversible ones. Or maybe you're more familiar with reversible monoamine oxidase inhibitors as far as harmala alkaloids and from the ayahuasca vine or Syrian rue, but those are the targets there. Your second generation antipsychotics or atypical antipsychotics are blocking serotonin 2A receptors. And you actually have some antidepressants and antidepressants repurposed as sleep aids, things like mirtazapine and trazodone, that are also able to block these serotonin 2A receptors. And most of these drugs here also bind to other receptors and other neurotransmitter systems. So I am kind of distilling it down here and talking specifically about their action in the serotonin neurotransmitter system. This is your serotonin synapse with an SSRI. So it just blocks the serotonin reuptake pump. It's a selective serotonin reuptake inhibitor. You have things like SNRIs that also block norepinephrine reuptake, but the crux of their mechanism is probably still blocking serotonin reuptake. You have some newer ones, the SPARI, serotonin partial agonist and reuptake inhibitors. Again, probably the crux of their mechanism is blocking the serotonin reuptake pump. So sometimes I get questions about like, well, what about an SNRI? And for intents and purposes of thinking about interactions with psychedelic substances, I think of SNRIs and SSRIs as almost identical as far as their interaction effects or risks. So when you block the serotonin reuptake pump, you increase the amount of serotonin in your synapse. And for a long time, there was this, well, increased serotonin, it makes you happier, and that's how it works. It balances a neurotransmitter, but that really doesn't make any sense at all because it blocks the serotonin reuptake pump on day one, but it's usually weeks to even months later that the person starts to feel better. So blocking serotonin reuptake is a very indirect type of mechanism, and it's probably neuroadaptive events that are happening over periods of weeks to months that really change the way a person thinks or feels. And these long-term neuroadaptation events I'm mentioning specifically because beyond sort of like, well, what happens when you mix them when people are taking both at the same time? Well, that's one question, right? But then the other question is sort of like, well, what if they've discontinued their SSRI and maybe it's even left their body, but some of these neuroadaptative events are persistent or taking longer periods of time to kind of come back to the way that the system may have been a baseline, if it even comes back to that kind of baseline. So SSRIs tend to downregulate postsynaptic serotonin receptors, and this could be one reason why you see some blunting. And they also tend to downregulate the serotonin reuptake pump themselves. So these neuroadaptive events, particularly downregulation of the postsynaptic receptors, probably helps to explain why something like psilocybin or LSD would be blunted, because they shouldn't on paper if you just kind of looked at it with diagrams like this. So kind of, following up with that from the last slide, this slide could be psilocybin or LSD, maybe DMT or dimethyltryptamine. Those are the three classic tryptamine psychedelics. And I'm focusing specifically on serotonin 2A synapses because it seems like this synapse or this receptor is critically important to the psychedelic effects. There are probably other serotonin receptors involved as well, but we know that if we block the serotonin 2A receptor with an atypical antipsychotic, things like psilocybin just really dud and fizzle. So it seems that this is just very important. Classic tryptamines are partial agonists, and what I mean by that is that they cannot fully stimulate these postsynaptic serotonin receptors, and they're unable to increase the amount of intrasynaptic serotonin. So this probably plays into the safety profile of things like psilocybin and LSD. There's very few psychoactive drugs out there in the world that you can survive a 100-fold overdose. And it's probably because there's a ceiling effect on how much serotonin stimulation can occur from something like psilocybin or LSD. Very interestingly, things like these classic tryptamines, when they bind serotonin 2A receptors, give a partial serotonin signal, but they also cause some very unique type of signaling to occur. And this is sometimes called biased agonism or functional selectivity. So that's why you see like these pink things as far as psychedelic signaling and the yellow as far as serotonin signaling. So they're very strong as far as the psychedelic or psychoactive effects, but as far as the serotonergic signal, which is probably what you think about if you're considering risk for like serotonin syndrome or serotonin toxicity, they have a ceiling effect, and that's probably why you don't see it so much with things like psilocybin or LSD. MDMA is a little bit more complicated as far as how it works. It blocks, this is VMAT2 or vesicular monoamine transporter. And what this does is it causes these serotonin vesicles to become leaky and to start dumping serotonin. And what actually happens is that the serotonin reuptake pump, which normally takes serotonin from the synaptic cleft into the presynaptic nerve terminal, reverses its direction, and the serotonin actually gets released out of the serotonin transporter. So this is probably why like MDMA has a much stronger interaction potential with SSRIs, because they block the ability of MDMA to release serotonin. MDMA increases intrasynaptic serotonin. So MDMA is the type of substance that it is possible to overdose on, and it is possible to get serotonin toxicities from, because if you're increasing the amount of intrasynaptic serotonin, then you are getting more of that serotonin signal postsynaptically. MDMA can also bind serotonin 2A receptors itself. It's much weaker as far as how it binds this receptor compared to something like psilocybin, particularly LSD, which is extremely potent in its ability to stimulate that receptor. And there's more pharmacology to MDMA that I'll get to later in the presentation. But essentially, carrier-mediated release of serotonin through VMAT2 and the serotonin reuptake pump is kind of what the literature has decided is the primary mechanism of a drug like MDMA. All right, so let's talk a little bit more about interaction between these classes of substances now. I'm going to focus again on SSRIs, SNRIs, and SPARIs, which we can more or less consider to be serotonin reuptake inhibitors. Talk a little bit about trazodone and mirtazapine, as well as bupropion, because they are commonly used, and at least according to the American Psychiatric Association's depression guideline for adults, they are first-line recommendations. So you could essentially just start someone on Wellbutrin, even if they've never tried an SSRI, and per the guideline, that would be just fine choice. Things like tricyclic antidepressants get used a little bit less. Sometimes you see them for obsessive compulsive disorder. Sometimes you see low doses for sleep or neuropathic pain, but they're not quite as common, particularly just straight up for depression. The monoamine oxidase inhibitors, at least the irreversible, real old school ones, are not used very often anymore. You may see like selective ones like selegiline or MSAM that are selective for monoamine oxidase B still out there somewhat. And particularly from Australian literature, there's more discussion of meclobamide than other places. And meclobamide isn't approved on the US market, so I never see it over here. So maybe you guys would actually see that more often. All right, so let's talk about these serotonin reuptake blockers. They almost abolish the effects of MDMA, and it seems like they could even diminish the effects of MDMA for weeks and potentially months after they've been discontinued. And because there's more data on this, I'm gonna come back to MDMA as a specific example. Plus or minus diminishes effects of LSD and psilocybin. So Kit Bonson in the late 90s did a subjective effects study that pre-treated people with SSRIs and gave them LSD, and that really did, they had people that reported diminished subjective effects of LSD. In my personal practice, it's a real mixed bag, particularly with psilocybin. Some people get really strong therapeutic effects of psilocybin while taking SSRIs, or even report that microdosing psilocybin is helpful for them while they're taking SSRIs. Whereas some people, I've had people like, well, I took 5 grams of mushrooms and I was taking Paxil, and I don't know, I just took a nap, nothing happened at all. So it seems like there's a lot of variability in this type of interaction. But what I do know, and I'm fairly confident about, is there's very little risk of true like serotonin syndromes or serotonin toxicities mixing things like LSD or psilocybin with the serotonin reuptake inhibitors. Again, because LSD and psilocybin just don't have the pharmacological profile to cause excessive serotonin signaling. Monoamine oxidase inhibitors and SSRIs, things like meclobamide, the irreversible old school ones, Harmala alkaloids probably are pretty dangerous with serotonin reuptake inhibitors, and they probably can cause life-threatening types of toxicities. I haven't really talked about pharmacokinetics at all yet, but many of these antidepressants inhibit a liver enzyme called CYP2D6, and this is a critical enzyme for ibogaine metabolism. Ibogaine is metabolized to noribogaine, which is also active through this. And ibogaine is also the type of psychedelic that doesn't have a real high therapeutic index, meaning that if you increase the dose twofold, someone could be in real hot water there and have some type of cardiac arrhythmia. So most SSRIs, if not all of them, are going to be contraindicated with ibogaine because of cardiotoxicity, potentially just pharmacodynamic risk too, but it's kind of a black box that's never been studied. Ketamine is the one that is compatible with SSRIs or SNRIs. When they're doing their original studies with ketamine, they always had people wash out their SSRIs or SNRIs. However, when they studied the nasal spray S-ketamine that's on the market and currently approved here in the US, they required people to be taking SSRIs, and it's actually part of the indication now. It's for treatment of refractory depression in people that are taking adjunctive antidepressants. And I don't mean to say that they have to stay on their antidepressants to use ketamine successfully, only that if you're looking for a psychedelic that's friendly with SSRIs or SNRIs, ketamine is the ticket currently. Wellbutrin is different than SSRIs or SNRIs. It does not have any activity really at serotonin synapses. It's mostly a dopamine and norepinephrine reuptake inhibitor. It's actually a mild type of psychostimulant. If you look at the structure of bupropion, it's a cathinone, and I don't know, cathinones now are out there as far as bath salts is what they're kind of commonly called, but they're phenethylamines cathinones as well. So they're derivatives of things like amphetamine and stimulants. Other drugs that block dopamine and norepinephrine reuptake include things like methylphenidate or Ritalin, and then also cocaine. Different degrees of blocking the reuptake, different durations of action give very different sort of profiles as far as how the drugs are used out there in the world. But saying all of this just to hammer home the point that bupropion is actually a mild stimulant rather than like a serotonin reuptake blocker. So there may not be a real risk of serotonin syndrome with Wellbutrin and MAOIs or Wellbutrin and things like ayahuasca, because Wellbutrin's not serotonergic, but because it's a stimulant, maybe you could run into hypertensive crisis. And Wellbutrin inhibits liver enzymes too. It inhibits 2D6 and 2B6. So again, thinking back to ibogaine, well, yeah, that's going to jack up the ibogaine concentrations. And there actually is one study out there with MDMA and Wellbutrin that demonstrated that not only does Wellbutrin increase the duration and intensity and blood concentrations of MDMA, but MDMA increases the blood concentrations of Wellbutrin. So they kind of interact with each other in that way. And Wellbutrin is also a drug that's contraindicated in epilepsy as well as restrictive eating disorders or people of extreme low body weights because of the seizure risks. So because MDMA has some mechanisms that can increase seizure risk, it can drop sodium. It's an excitatory type of stimulant. It can raise core body temperatures. I'm pretty concerned about this combination as far as like increasing the risk of seizures. And there was one post-marketing surveillance study that just came out. I think it was either earlier this year or late 2020. that demonstrated from the FDA's adverse events reporting system that the combination of MDMA and bupropion was the highest risk of death among any combinations of antidepressants that they could find. So in this lab experiment where they actually combined, the doses were fairly low, and I'm sure they screened people for all these seizures. They're not in a nightlife setting where it's very, very hot and things like that. So they didn't observe any serious adverse effects there. But I think kind of extrapolating out to larger doses or people that are doing different things. I mean, frankly, here in the United States, there's patients that will crush and snort Wellbutrin. So there probably is some risk there. Mirtazapine and trazodone are a little bit different in that they probably are unlikely to cause much in the way of real serious drug interaction or adverse effects, even with things like ayahuasca, because they either don't increase intrasynaptic serotonin or they really minimally do at lower doses. Whereas if you start pushing the dose of these types of medications, and particularly trazodone does start blocking the serotonin reuptake pump, so probably does become dangerous. Although I was able to find this study from 1990 that essentially combined, people that were on 50 to 100 milligrams of trazodone with monoamine oxidase inhibitors, and all of them in that study tolerated it fine. Mirtazapine isn't really a drug that's associated with serotonin syndrome or serious adverse effects like that very often, but there are some, I don't know, I want to say like idiosyncratic types of case reports out there. So maybe, but they do block serotonin 2A receptors, even at low doses, these two types of medications. And again, that serotonin 2A receptor is probably pretty critical for the ability of serotonergic psychedelics to have psychedelic effects. Trazodone in particular also has some QTC prolongation, which probably increases risks of cardiotoxicity with ibogaine. And again, ketamine is the one that could be used safely with each of those. So I do have a kind of like a master drug interaction chart that is available. If you have to sign up to my email list, but it gets emailed directly to you if you want. It's like 2 or 3 pages long, is why I could have just like pasted onto this slide. But I'm going to put this link into the chat box right now in case anyone wants to access that as a resource. Okay, so I mentioned at the beginning that there's much more research and data and probably interaction risk between antidepressants and MDMA. So I'm going to cover some of that in a little bit more detail now. MDMA primarily releases serotonin, but it can also release norepinephrine and dopamine. It does this to a lesser extent than your kind of classic amphetamines like D-amphetamine or dextroamphetamine, but it can do that. Has neurohormonal effects. So release of oxytocin, this is a social bonding type of neuropeptide. So maybe this is actually part of how MDMA enhances a sense of connectedness, or maybe fosters additional trust between people. So the release of oxytocin is probably maybe related more to like therapeutic effects, but the release of AVP or arginine vasopressin, sometimes it's called antidiuretic hormone, can drop body sodium sometimes and result in a syndrome called SIADH, or the syndrome of inappropriate antidiuretic hormone. There's also pharmacokinetic types of interactions or interactions possible through the liver with MDMA, and it's probably 2D6 that does a lot of MDMA's metabolism, but there's other enzymes that are implicated, and not so much in the realm of psychiatric medications, but there are some medications out there like ritonavir or cobicistat that are used in the treatment of HIV or AIDS that are kind of like pan liver inhibitors or inhibit multiple ones of these enzymes. And there have been essentially cases of severe MDMA toxicity or even death occurring mixing things like ritonavir with MDMA. And going back to Wellbutrin, again, 2D6 and 2B6 is inhibited by Wellbutrin, so perhaps explains why there's more interaction risk there from a kinetic or metabolic perspective than other types of antidepressants. There's some clinical experiments that I'm going to go over. There's also recreational ecstasy data out there, and some of it is in agreement and some of it seems like it's a little bit at odds with each other. And this could have to do with the types of sets and settings that recreational MDMA or ecstasy is used versus the clinical experiments. It could have to do with dosing, it could have to do with impurities, it could have to do with the types of other things that people are mixing with ecstasy out there. So that's my best guess of why you see some real discrepancies sometimes between clinical experiments and sort of just observational research that's out there from what people are doing in the world. So this is a chart of different randomized placebo-controlled crossover studies that people have done looking at different types of particularly serotonin reuptake blocking antidepressants like the SSRIs or SNRIs, but you also see Wellbutrin, that study that I was mentioning earlier down here on the bottom. And what you notice is that globally, if it's an antidepressant that blocks the serotonin reuptake pump and it's a clinical experiment, the subjective effects of MDMA are decreased across the board. Interestingly, because some of these antidepressants block liver enzymes like 2D6, you see increased concentrations of MDMA in the blood, yet for the most part, decreased physiological parameters. So this is really interesting that from a metabolic or kinetic perspective, there's an interaction where the blood concentrations of MDMA are increased, but because the serotonin reuptake inhibitors block the ability of MDMA to release serotonin, you actually see diminished subjective effects and diminished even physiological responses to MDMA. Wellbutrin was different. You saw increased duration of MDMA experiences, increased intensity of the experience, as well as increased blood concentrations. You did see a blunting of heart rates. So this probably has to do with the fact that Wellbutrin blocks dopamine and norepinephrine. MDMA is able to release norepinephrine and dopamine, so you got less cardiac stimulation from the couple. But as far as subjective effects of MDMA, because it's primarily about releasing serotonin, you see an increased intensity of things. So does recent tapering of antidepressants reduce the efficacy of MDMA-assisted therapy? I think it's still an open question, and we're still needing a little bit more data to truly understand what's going on here. In the phase 2 trials of MDMA, there were 6 done. There was a retrospective analysis that picked people that got active MDMA, so they didn't include people that were getting placebo because that didn't really make sense for their analysis. And they divided them into people that had recently tapered an antidepressant versus people that had been on antidepressants in the past, but were not on an antidepressant at the time that they went through the study enrollment types of procedures. So for the people that have recently tapered antidepressants, they were off for a mean period of 25 days or 3.5 weeks. And they found that they were not getting as good a results from MDMA. And I'm not talking about subjective effects now. Now I'm talking about therapeutic outcomes like improvements in symptoms of PTSD. And it's not just with one session of MDMA either. They saw that in people that are recently tapered antidepressants that had gotten 2 MDMA sessions spaced about a month apart, and then measured their PTSD symptoms 1 to 2 months after that, only 25% of people in the recently tapered group didn't meet a PTSD diagnostic criteria, whereas almost 2/3 in the non-tapered group did. So it seemed like from this that there was a really big difference between people that had tapered antidepressants recently, and those that hadn't. And the amount of time it takes an antidepressant to leave the body, meaning that you cannot detect it in blood or urine, for the most part is 7 to 10 days, maybe up to 2 weeks. Prozac's much longer, but all the others, 2 weeks should be plenty of time. So they're off for 3.5 weeks. They're not getting very good results. 1 or 2 MDMA sessions later, it's like this was extremely concerning. This result for persons taking antidepressants that could benefit from MDMA-assisted therapies. There's been a single phase 3 trial published about MDMA-assisted therapy at this point. And in this trial, they didn't find that signal. It kind of dried up. So persons that had recently tapered serotonin or paroxetine had similar results to everyone else. But this trial, phase 3 now, they're using 3 MDMA sessions spaced a month apart and measuring it 2 months later. So I'm not really sure exactly what the deal is. I'm kind of thinking of this week, the kind of like minimum study criteria of being off 2 weeks is probably not quite long enough to give a potent first MDMA session. It could also be that the people that are recently tapering off of antidepressants are going through a withdrawal syndrome 3 or 4 weeks later. And that could be another reason why they don't feel so good, particularly after the first and maybe even after the second MDMA session. Whereas, if you taper them off and really give them 3 sessions, this signal kind of dried up. So I think it's kind of reassuring that at some point, we know that people probably will start to respond to MDMA treatments. But I think the kind of take home that I've been discussing with people is that particularly when you're coming from a world of traditional antidepressants like SSRIs, you probably should temper your expectations about that first session. And really just hits home what I think we've known is that this is a real therapeutic process that probably takes a number of sessions and work before, during, and after to really get there for everyone. So it may turn out that 4 or 5 sessions is going to be ideal for people that have recently tapered antidepressants, because that first one may not be that helpful for them, or at minimum kind of 3, it seems like. So MOIs or SSRIs with MDMA compared. So this is kind of as complicated as my diagrams are going to get here. Basically, you see with monoamine oxidase inhibitors, I guess backing up for a second, monoamine oxidase inhibitors, SSRIs, and MDMA are 3 different types of drugs that can all increase intrasynaptic serotonin. And if you're thinking of serotonin syndrome, of serotonin toxicity, you should be thinking of which drugs increase intrasynaptic serotonin, because those are the ones that classically cause that type of adverse effect. So with MAOIs and MDMA, MDMA is able to release serotonin through carrier-mediated release. So that increases intrasynaptic serotonin. And the MAOI prevents the ability from serotonin to be degraded. So that one's a double whammy. There's a synergistic type of interaction there where, that's a deadly combination. And, particularly these 2 papers by Vawori and Pilgrim are both about meclobemide MDMA, and it's data from Australia, actually. And they document either severe serotonin toxicities or death with this combination. Whereas MDMA with SSRIs, it's almost like although independently, they can increase intrasynaptic serotonin. When you combine them, the SSRI really blocks the ability of MDMA to increase intrasynaptic serotonin. This is probably why you just see kind of dud combinations, or the most common experience is going to be, well, I took MDMA on my SSRI and nothing happened, rather than everything happened to the point that there was real toxicity. There's this one paper, again, like this paper by Cohen that was just released not too long ago, that looked at the FDA's adverse event reporting system. And they did find an increased risk or odds ratio of mortality or death with some SSRI antidepressants and MDMA. And it wasn't the ones that we would necessarily expect. So this was kind of like a head scratching type of result here. And I think what I'm kind of chalking it up to is, when we're talking about recreational ecstasy, we're not really sure what doses or routes of administration and things like that people are using. But if you're thinking from the perspective of a clinician or a practitioner in MDMA assisted therapy with moderate doses in controlled environments, I think you can really expect more diminished effects rather than increased risks of toxicity. All right, let's take us home here with some taper and washout of antidepressants. So antidepressant withdrawal is probably the most dangerous when people just abruptly stop their antidepressant all at once. But there are relative states of withdrawal syndromes that can occur just with normal types of dose decreases in the tapering process. And it probably won't happen if you took an SSRI for a week or two, got some side effects, decided you didn't like it. Yeah, you're probably on the lowest rung of the dose at that point. You haven't been taking it for very long. So there's no, well, I don't know, I don't want to say no harm, but you're not going to get a physical withdrawal or sin because you haven't been taking it long enough for to be dependent on it at that point. But if you've been taking antidepressants for a couple of months or longer, then there probably would be some type of dependence and potentially some type of withdrawal syndrome to stopping. There seems to be a lot of variability in the sensitivity to SSRI withdrawal. I mean, some people that are like, yeah, I stopped 300 milligrams of Effexor and I didn't notice anything. And it's like, wow, the Effexor has like a real reputation for being difficult to stop, and this person's not reporting anything. Prozac is, because it's so long acting, it tends to be more forgiving. Maybe the withdrawal is more protracted, but it's much more mild. Yet I meet people that's kind of like, man, every time I step down Prozac, I get a pretty tough withdrawal type of syndrome occurring. So there's a lot of variability here. And many continue actually taking antidepressants not because they're working well for them, but because they're afraid of the withdrawal effects or have experienced those. And there's a lot of research about how to start SSRIs in those first few weeks of use, first few months of use, but there's a whole lot less research about how to taper them, how to get off of them. Most antidepressants are prescribed through general medicine or general practitioners, family care doctors that aren't experts or specialists in psychiatric medications. So a lot of people I meet are just taking antidepressants for years and years and years and not really feeling that well, but essentially kind of stuck with them because every time they try to step down or stop, they run into some debilitating withdrawal. So this is something that psychiatry has paid a little bit more attention to in the last couple of years. So I don't know, that's promising, but Prozac was brought to the market in the late 80s. So I think a lot of patients are really frustrated and sad that this wasn't something that they were told about up front when they were beginning to start the medication. So tapering antidepressants does reduce the risk of withdrawal and the risks associated with that. And it does increase the chances of success, particularly compared to abrupt discontinuation, which really can precipitate psychiatric crises in people. As far as washout times between antidepressants and psychedelics, you may want to wash out an antidepressant to gain an optimal experience effect. So something like MDMA or psilocybin, where probably combining the antidepressant is not a real serious risk as far as like physical adverse effects, but it could really squash or diminish the potency of the experience. So many people may want to wash it out for that reason. Or, if you're considering things like ibogaine or ayahuasca, you're going to need to wash it out due to safety concerns. The minimum washout times that they've used in clinical trials are based on waiting 5 medication half-lives, and this is essentially a general rule of thumb as far as how long it takes a drug to leave the body. However, the sort of neuroadaptive responses, even after the drugs have left the body, may be a little bit more persistent and take things like weeks or months to really reverse. So there's a lot of variability here, right? Like you could probably imagine some situations where tapering the antidepressant is so difficult and so tough that a person may just want to try something like psilocybin while taking their antidepressant, because getting off is just not something they've been able to accomplish. Whereas, some people, it might be that, well, I can get off, but, waiting 8 weeks, that's going to leave me hanging for those 2 months. So even though the first session may be a little watered down or diminished, maybe it does really favor beginning the work with psychedelic therapies 2 or 3 weeks off of the antidepressants instead of waiting this longer period of time. So, I'm kind of thinking a minimum of 2 weeks, unless you're Prozac, and then it's 6 weeks, but a minimum of 2 weeks for all of the SSRI, SNRI, SPARIs, with the exception of Prozac. There's probably better to wait 4 to 12 weeks if it's possible. And again, there's a lot of kind of clinical gray area there about whether that is possible for the person or whether they're truly able to do that. Antidepressant withdrawal reactions are sort of broadly categorized into rebound symptoms, and this is sort of just a nasty and quick return of the types of symptoms that bothered them initially, and sometimes they can even be more pronounced or severe than the symptoms were at baseline, but essentially they mimic the types of things they have. So, sometimes you hear things like, well, I stopped my antidepressant, or I went down a dose, and 48 hours later, I was just horribly depressed, or I was like very anxious. And, it's like, so I know that I'm still depressed, so I went back on it. It's kind of like, well, actually, I'm not sure if you know that you're really depressed still. I think that what you experienced was a rebound phenomenon or a rebound type of symptom. And actually, if you're able to stay off of it for a longer period of time, you may notice that those types of things abate or resolve over time. There's also antidepressant discontinuation syndromes, which are symptoms that are just unique to the antidepressant withdrawal phenomenon. These things include fatigue, nausea, like neurological phenomena, like sometimes people experience things like brain zaps or almost like an electric shock sensation. They can feel like paresthesias or like a tingling in their especially their extremities, like their arms or legs. I've had people feel like vertigo, tinnitus, or like ringing in the ears. So there can be like neurological types of issues that come up, and standard things, insomnia, headache, that type of stuff is part of it as well. So particularly, you got some rebound, you got some symptoms of illness along with these sort of other unique effects. Like I usually kind of think like, well, that sounds like more like withdrawal rather than return of your sort of original illness or underlying condition. The current standards for tapering are pretty aggressive. They suggest tapering slowly over 2 to 4 weeks, which, if you're on 200 milligrams of sertraline or Zoloft, I mean, you're stepping down 50 milligrams every 4 to 7 days. And if you're thinking, well, geez, it takes 2 to 6 weeks for it to take effect, and you're stepping down every 4 to 7 days, I mean, that just seems like you're going too fast. And for a lot of people, they really do experience it as being too fast.
And just
That's
giving
the
you, we've got about 15 minutes, so just wanting to check in with you.
I'm on slide 34 or 39, so I think we're in pretty good shape here. Yeah.
Thank you.
Yeah. The medical literature has a lot of gaps in the information here. So for myself personally, I recommend people taper 10 to 25% of their dose every 2 to 6 weeks as tolerated. So take a step down, do your 2 to 6 weeks, feeling better, take another step. You're not feeling better after 2 weeks, wait another 2 weeks, right? So instead of thinking that we're just going to go down on the same kind of pattern the entire way, and that's the plan, and that's what we're going to stick to, I advocate much more of sort of like listen to yourself as you go. Take it slowly. You've been on this drug for 5 years, 10 years. Don't try to get off of it in 1 month. Try and take at least 2 to 3. And, if you're really sensitive to withdrawal, you may have to take more like 4 to 6. this is sort of like a temporal graphic of what you may expect. And whenever you step down an antidepressant, you can probably expect that mood is going to take a hit, anxiety could come up, and depending on how large the step down, this may be tolerable or not. So the red line is like not like that sounds not so good. You're hoping that you're kind of taking down, tapering or taking down a step, so that by weeks 2 or 3, the person's feeling pretty good. They're almost back to baseline, and they can kind of keep going there. Dose decreases are relative. So if you start with 100 milligrams of sertraline and decrease it by 25 milligrams, that's a 25% reduction. But once you go from 50 milligrams to 25, that's a 50% relative reduction from where you were. So oftentimes people find that the closer they get to the finish line, the tougher it becomes. And that last step, going from some drug to no drug, is oftentimes the most difficult one. It could be that, if people are stepping down, if you're having more like a yellow here, like a moderate withdrawal reaction, and you're stepping down every 2 weeks, but it takes 4 weeks for you to get back to a baseline, the withdrawal effects could start stacking on you. And you may end up in the kind of red zone after 2 or 3 steps, even though the beginning was going okay. So again, listening to yourself and trying to wait till you're feeling close to the way you were before you step down is ideal. So I think that we can kind of conclude here that, if you're tapering antidepressants and going towards psychedelic therapies, it's probably going to take some advanced planning, particularly if you're someone that's sensitive to the withdrawal effects. This graphic here is for ayahuasca, which is like a real contraindication with the serotonin reuptake inhibitors. But you could also have the same type of idea if you were approaching psilocybin or MDMA and you're really trying to have the most kind of potent experience possible. So yeah, it may be a number of months of preparation before someone is ready. And I think this is kind of like my plug, is that there's so much discussion about integration therapy or preparation for psychedelic experiences, and particularly like integration afterwards. But for people coming from a world of traditional antidepressants, the most challenging part of this process may be actually getting to their first experience. And I think a lot of the skill sets that are taught as far as emotionally supporting people through psychedelic experiences and through the effects afterwards are relatively applicable to people that are tapering antidepressants and going through a withdrawal. I mean, whether it's a drug-induced withdrawal or a hard time in life or something after a psychedelic experience, there's probably just some commonality as far as like how to help human beings through that process. So I've got a course in this. The course has like an antidepressant taper planning and monitoring support kit. It's going to be a very confusing time for people. Maybe it's withdrawal, maybe it's return of illness. Maybe it's neither of those, and life just got hard all of a sudden. My boss asked extra things of me at work. I was having more difficulty with my partner. Sometimes things just happen in people's life, psychosocial stressors, for example. Maybe people are starting new medications or new supplements or adding ketamine to the mix in all of this. So it can become rather confusing as far as understanding like what is what here? Like, is this the post effect of this, or is this the withdrawal from that? I designed something where it's essentially people can kind of track what happens. Like you take a step down your antidepressant, track your mood, your anxiety, track some of those specific withdrawal symptoms related to antidepressants, track sleep, and then people can graph their pattern, right? Because once they know that, well, every time I step down, the first few days are okay, and then wow, I am just raging irritable from day 6 through 15. That's useful information for them, because now they can arrange an extra appointment with their therapist or integration coach for that time. They can, essentially warn the people around them, like, I'm going through a process right now and I'm expecting the next week to be pretty difficult for me. So if you could just exercise a little more kindness and compassion and understand that what you're seeing out of me might be drug withdrawal and not necessarily who I am or what I think of you, during this time period, I think that those things can reduce harms of this type of stuff. Okay, summarize and conclude. Most antidepressants and psychedelics seem like they don't mix very well. Antidepressant tapering can be complex, and slow tapering is probably going to be needed, particularly in long-term users that have been taking high doses. And really monitoring, supporting people, planning, they're necessary to improve safety and achieve optimal benefits. Of course, I want you to join my membership program. So if you want, I'm giving everyone on this webinar, people at My Australia, $30 off the first month of membership with the webinar, and can also just have a link here somewhere. Can pop it into the chat box for you, if that's something that you would enjoy. But at this point, I'm ready to field some questions too, and we have 7 minutes, so
we can go a tiny bit over. I've just got to get my son to soccer at some point soon.
Yeah, and maybe some here.
Yeah, I just wanted to briefly, Ben, just say thank you for that. Just incredible wealth of knowledge. And I have a membership, and I've also had my own private consultation with Ben. And yeah, I'm really looking forward to seeing what we can weave over the coming years with the service that I run, the psychological support service, because I think, your skills and knowledge are really hugely beneficial for the clients that I support. So yes, thanks for being here today and putting up with the tech issues. So fire away with some of those questions, whatever you.
Yeah, well, it seems like James has a question about Wellbutrin and MDMA, and he's essentially wondering about the difference between MDMA and like methamphetamine use. Like there's some trials that will combine Wellbutrin and injectable naltrexone to reduce stimulant use disorders or methamphetamine use disorders. So bupropion to help cravings for ice, yet MDMA is contraindicated. Yeah, so the idea here, right, is that people are using Wellbutrin to not use methamphetamine, but using methamphetamine with Wellbutrin could increase the risk of seizures. And yeah, particularly in the US, I've not so much outpatient psychiatry, but inpatient psychiatry, people that come in that their urine toxicology is positive for amphetamines, the psychiatrists really pause before they prescribe them Wellbutrin. And I've personally seen it a number of times, patients in the inpatient psychiatric units cheeking their Wellbutrin, going back to their rooms, crushing it and snorting it. So Wellbutrin is not a controlled substance, but there probably is some interaction risk there. And if people are really motivated to stop stimulants, right? They're in a treatment facility. They're like, what can we do, doctor? I really don't want to go back to that. Then yeah, it really makes sense. Like Wellbutrin could lift some of the post-stimulant use type of anhedonia and give them a little bit of a boost of dopamine and norepinephrine without really pushing them over into the types of adverse effects that methamphetamine use has. But combining methamphetamine and Wellbutrin is probably not a great idea the same way it's not with MDMA either. My uncle was taking Soliant. What's the generic name for that one? It's not a US brand name, so I got to figure it out which one you're talking about here. Soliant. Does anyone know? Type it in if you know the generic for Soliant. Veronica G, overall, psychedelics work better than antidepressants. I think so. I think we'll see that eventually. There's very little head-to-head data at the moment. The only head-to-head trial was the one that was published in the New England Journal just a month or two ago with psilocybin versus Lexapro. And their primary outcome for that study, their QIDS depression rating score was they say non-inferior. As far as like raw decreases in depression, psilocybin did have a little bit of an edge, but it wasn't statistically better. However, a lot of the secondary measures, in fact, all the secondary measures, psilocybin beat Lexapro. Things like overall well-being, quality of life. This study only had 60 people and it was only 6 weeks long. So I do think that we're going to have some definitive evidence pretty soon that psychedelic therapies probably have an edge over the traditional types of antidepressants. A lot of the times, the traditional antidepressants don't beat placebo in trials. There's a publication bias in the literature that favors studies being published that show that antidepressants work, where there's a lot of trials that drug companies have done where essentially the antidepressant failed and they didn't publish the result. It never saw the light of day in medical literature. And particularly for people that have tried antidepressants and failed them, right? Like the treatment-resistant depression, the treatment-refractory PTSD is part of their criteria that they've tried these things and it doesn't work. And then they're trying the psychedelic therapies and getting really profound types of clinical benefits. So I think I would have to, on the whole, agree that the efficacy of psychedelics and maybe the safety profile of them too, frankly, is a little better than antidepressants. But as far as a big head-to-head trial that clearly shows superiority, we have not produced that piece of data quite yet.
Just another 5 minutes. What would you like to answer?
Amisulpride. I believe amisulpride is a type of antipsychotic, isn't it? Yeah, it's an antiemetic and antipsychotic medication. I think it's a first generation too. I don't think it's a second generation. So the first generation antipsychotics don't block dopamine, or they don't block serotonin 2A receptors usually. They usually block just D2 or like dopamine receptors as far as their mechanism of action. I've not seen any data specific to amisulpride, but there's one experiment out there that Vollenweider and his group did in the late 90s that showed that the typical antipsychotic Haldol, when they gave that before people that had a psilocybin, the people still had psilocybin experiences, but they had dysphoric, anxious, ego dissolutive types of experiences. So it seemed like the typical antipsychotics didn't block the effects of psilocybin, but they exacerbated the negative aspects of the psilocybin experience. So I don't think amisulpride is really very compatible with psilocybin for that reason. Not necessarily serotonin syndrome and not necessarily like no psychedelic effect, but just not the type of psychedelic effect that you're really looking for or would hope for.
Ben, can you comment on an ECT and psychedelics and if it
yeah, like as far as like efficacy comparison. I mean, so ECT, is like a electroconvulsive therapy, or sometimes called like electric shock therapy. Is a pretty old school treatment for refractory types of depression, particularly, but also psychosis and things like that as well. There's also some other newer modalities like RTMS, or rapid or repetitive transmagnetic stimulation. And the interesting part about all this is like ECT is almost like, it is inducing a controlled seizure. The RTMS is using magnets essentially to stimulate or interact with certain parts of the brain. And then you have things like ketamine, as well as the serotonergic psychedelics. And it's really interesting how all of them across the board tend to focus on areas of the prefrontal cortex, like the dorsolateral prefrontal cortex. So it's very interesting, actually, that it seems like there's some convergence between pretty disparate types of treatments out there for refractory depression. ECT, because it induces a seizure, can really leave people with some problems with like memory and cognition afterwards. This is probably the downside of ECT. ECT, you also have to get usually a series of 12 treatments. You do it 3 times a week for a month straight. So it's kind of like, yeah, you're going to go have a controlled seizure every 3 days or 4 days for a month and I mean, that exactly. It's inconvenient. You have to do it inpatient. And, you know, compared to a mystical experience, it's probably not quite as fun either. Not that psychedelics are fun necessarily, but I think if you just ask the average person, what would you prefer as far as your treatment, then they would lean towards a psychedelic therapy. Does psilocybin affect the effectiveness of your antidepressants if taken in parallel? This is a great question. And from what I can tell is that they sort of have, again, opposing mechanisms as far as their coping mechanisms, or, you know, their effects on facial recognition patterns and things of that nature. But even in the paper that I cited about coping mechanism, it's Carhart Harris and David Nutt that wrote that review article called A Tale of Two Receptors about serotonin 1A and 2 receptors. Fantastic article, just a fantastic article. Even in there, they sort of say at the end, you know, it's sort of like, well, until we really test it, you know, like, how do we know that these two sets of coping mechanisms are really opposites of each other and squashing and counterproductive? And I think my sort of feelings of it is there might be a place for it all, and that, you know, maybe when people are truly in crisis in their life, or they're not in a place where they can rearrange their life, they can't undergo a transformation because of the restrictions around the relationships or their work or their financial constraints and things like that. There may be times in life where weathering the storm really is the way for them to go. But there comes a time in people's healing processes where they're more stable, and they are in a position to do some deeper work or change aspects of their life. And that might be where, you know, activating those active coping mechanisms make a lot more sense. And that's essentially the story of a lot of people I talk to. They're kind of like, well, man, you know what? I don't like being on an antidepressant now, but my God, when I started it 7 years ago, it pulled me out of a deep, dark hole. And, you know, I don't like being physically dependent on it now. And I'm ready to transition and continue my healing journey with a different type of modality. But I can't truly say that it didn't help me at all.
So one more question, Ben, if that's all right.
Psychedelics and social anxiety. I haven't really tested it yet. I think that there's probably, you know, essentially, I think of social anxiety as the type of because social anxiety really kind of crops up usually around ages 11 through 14 is sort of like when it like really rears its head. So it's like when people are kind of solidifying or like coming into like a true sense of identity, and they're very, very sensitive to what they perceive to be the judgments of other people, but it's usually the self-judgments. It's like, oh, what are they going to think of me if I do this? If I wear these types of clothes, I'm going to look bad, right? So there's a lot of self-critical types of thoughts that come along with social anxiety that are sort of projected to, well, other people are thinking these things about me, so I'm anxious about that type of social interaction. But it's the internal judge. And yeah, I think psychedelics are the types of tools that can elucidate just who is doing the judging and maybe free them of that type of cycle. But, you know, I don't have an experiment I can point you to.
All right. Thank you, everyone. I know there's a lot more questions,
Yeah.
but I encourage you to, get a membership and even have your own consult with Ben. Really incredible for harm minimization, for safety, for you, for your clients. And yeah, thank you. I'm looking forward to collaborating again one day. And
yeah, thank you all for having me. And again, thank you so much to this audience for hopping around and this or that. And, you know, I hope that it wasn't too disruptive in all of it and that you're still able to get something good out of it.
Yeah, and we'll get the webinar link smooth and get that sent out to everyone with some. Is there any slides available, Ben, or anything we can send out?
Yeah, if you want me to send you the PDF or the deck, I can. That's fine.
Okay, awesome. All right, thanks everyone. Enjoy your
care.
Saturday.
Friday night.
Woo. Thanks, Ben. Appreciate it. Cheers.